This is a diabetic patient with maximum pupil dilation in spite of phenylephrine and tropicamide eye drops. We plan a large rhexis. I am going for a blind rhexis behind the pupil with my sysytem and taking care that I am able to maneuver easily. At any point of time, if I feel that the maneuvering is difficult, I am losing the chamber, we inject more viscoelastic so as to tamponate the anterior lens capsule and preventing the rhexis from running to the periphery. So I right now inject more viscoelastic. Again we complete the rhexis. As long as we are able to maneuver the rhexis in an anti-clockwise direction, that means we haven't lost the rhexis. We just are trying to make a large rhexis. I prefer injecting multiple spurts of PSS for cortical cleaving hydrodissection. Avoid a large spurt of fluid wave which might risk posterior capsule rupture. In these kind of cases we don't have a proper view. So choose multiple quadrants, inject small spurts, keep tapping the lens to decompress the fluid wave. Now I start with phacoemulsification. This is a centurion vision system. I make a small central sculpt and then go for a direct chop. So this small central sculpt gives me adequate space so that I can bury my phaco tip down into the center of the nucleus. Now I bury my phaco tip down, go all the way from the periphery to the center and create the first crack. It is not a complete crack, so I bury again, try to separate. Again we achieve the crack but not from one end to the other. Again find a deeper nuclear plane and try to achieve a crack, initiate the crack again. The aim is to have at least 4 to 5 nuclear pieces. Now we have achieved a complete crack over this side. And I am able to mobilize a free quadrant here. I am taking care not to go too much in the periphery with my phaco tip. Don't want to catch any of the iris tissue or capsule. Just bring the nuclear pieces into the center and then phacoemulsify them. It's very important to be slow. We don't want any turbulence in the anterior chamber. We have small pupil, inadequate view of capsule. We don't know how big our rhexis, so we have to be very slow and controlled in the whole surgery. Now I'm left with this epinuclear bowl and I'm scared to go and flip it with my phaco tip. So I inject some viscoelastic and with the Sinski I just elevate it out of the bag. Now with a Sinski I go behind and support this epinuclear bowl and the plan is to feed this last piece into the phaco tip directly. So I impale the phaco tip directly into the lens matter, and with again lower parameters, low vacuum and flow rate, emulsify. This is a fairly soft cataract, grade 2. And see how beautifully we are able to fake emulsify the whole lens. My preferred mode of corticus aspiration is coaxial irrigation aspiration. I'm going very slow, sometimes under the pupil, aspirating the cortex. Here I am having a little struggle for my subincisional cortex. I plan it to tackle at the end of it. I use bimanual now. I was not very comfortable at some essential point because of the inadequate pupillary dilatation. I remove the subincisional cortex with my bimanual irrigation aspiration. A single piece hydrophobic aspheric IOL is implanted with D cartridge using the 2.4 mm incision. The lens is centered into the bag. Residual viscoelastic aspirated with coaxial irrigation aspiration cannula. Main ports are hydrated, side ports are hydrated, and a watertight chamber is achieved.